Welcome to another episode of the AOT Pod, an FRCS themed podcast brought to you by the Association of Otolaryngologists in Training, hosted by myself, Josh Michaels, and Georgie Wellstead, with the support from the ENT UK Foundation. Today I am pleased and privileged to hear from Rahul Pankhania, a North Thames trainee, and Mr. Bhav Patel, a consultant otolaryngologist and gold medal winner at Northwick Park Hospital. Thank you very much for listening and to enjoy.
Great, I'm Rahul Pankhania and today we are discussing otosclerosis, and I'm absolutely delighted to have Mr. Bhav Patel, an ENT consultant at Northwick Park Hospital and FRCS gold medal winner. He has a particular interest in otosclerosis and a high volume of stapes surgery. So thank you for joining us today.
Thanks so much for having me, Rahul. It's a real privilege to be joining on the podcast today.
Yes, and we're very delighted to have you as well. So to start off, we're just going to do some quick fire questions to ease you in. So could you tell us, when you took your exam, what was going on in your life at the time and when you were preparing for this?
Sure. So I took the exam in 2021, and at the time I was working for Anuj Majithia and Arvind Singh, who are two excellent otologists and colleagues of mine. It was a really good job, and I really enjoyed the clinical aspect of the job. And alongside that, my first son had just been born 6 months earlier, so I was juggling work with family. And on top of that, I was trying to study for the exam. It's a busy period of life, but provided that one practices far enough in advance and is organised with their time, it's quite achievable to be able to manage revision alongside the other commitments.
Yeah, definitely some wise words there, and I think that's what many people can, definitely relate to, and what they find challenging about this is to try and get time in. So what were some of the challenges that you were finding, and were there any top tips you found in managing them?
Sure. I think the key is to try and find opportunities to revise and practice throughout the days and carve opportunities to micro-learn. So finding space in between cases when you're in theatre, perhaps on your commute to and from work, and maybe an hour or so in the evenings, provided you use these opportunities over the period of around 3 months or so, along with a bit of study leave before each exam. That usually tends to be enough for most people.
Yeah, that's a really important point. I really like the sort of micro moments that you're getting there, those small periods of revision, which probably amount to quite a significant amount at the end. I suppose the important question then, how did you feel when you passed?
Yeah, it was a great relief to be done with exams forever. And it was also, it felt like quite a milestone moment in terms of my professional identity development. From when you start in your journey as an ENT specialist, you're always looking towards the FRCS as the final goal. And to have been at that moment is quite special, and it'll be special for yourselves and your listeners when they get to that stage, I'm sure.
And you were awarded the gold medal. Did that come as a surprise to you, or were you expecting it at all?
No, it came as a complete surprise, and my first response was to call the Royal College of Surgeons because I thought there was some mistake. So it was quite a surprise, but it was a nice
feeling afterwards. Yeah, definitely, and well deserved, I'm sure. So then, moving on to our clinical scenario, which is what we're here to discuss. So you have a 32-year-old female who presents to the ENT clinic with a 3-year history of bilateral hearing loss. Would you be able to describe your approach to the assessment of this patient?
Sure. As with any patient, the approach requires a full clinical history and examination. Key aspects of the history would include the onset, duration and progression of the hearing loss, along with any obvious risk factors for otosclerosis. So, for example, any pregnancies and any relationship between hearing loss and pregnancies. I'd also want to assess for any family history, as oftentimes patients may have a strong familial history of early onset hearing loss. It's also important to ask for any other otological symptoms that may point to an alternative diagnosis. So, for example, a superior semicircular canal dehiscence may present with hearing loss, but patients may also report autophony or noise and pressure-induced dizziness, known as Tullio's phenomenon. I'd want to ask about any recurrent infections, otalgia and otorrhea, that may point to an alternative diagnosis such as chronic suppurative otitis media and lateral chain fixation as a consequence of this. It's also important to ask about the patient's previous medical history, any previous otological surgery they may have had, along with their occupation, as oftentimes the decision for surgery may be coloured or informed by other non-medical aspects of their life. In addition to the history, it's important to perform a full otological examination, which would consist of micro-otoscopy. Typically, you would see normal appearance of the tympanic membrane. There is described the Schwartz sign, which is a flamingo pink appearance through a semi-translucent tympanic membrane, and this relates to increased vascularity over the promontory, which is found in active otosclerosis. It's quite rare, I must say, in my practice, and I've not seen it personally, although it's quite classically described in textbooks and sometimes comes up in examinations. As well as otoscopy, it's important to perform tuning fork tests, typically with a 512 Hz tuning fork. Perform both Weber's and Rinne's, along with applying a tuning fork on the elbow and the medial malleolus, which may point to superior semicircular canal dehiscence if the patient can hear this. I would correlate my clinical history and examination findings with audiometry, which would include air conduction and masked bone conduction thresholds as appropriate, along with acoustic reflexes.
So what would you expect to see on audiometry and tympanometry, and in particular the reflexes as well?
Audiometry typically shows a conductive hearing loss and classically a Carhart's notch, which is a reduction in the air-bone gap at around 2 kHz. It's important to say that the Carhart's notch is also seen in other tympano-ossicular causes of hearing loss, and therefore is not specific to otosclerosis. Tympanometry typically shows a type A trace, but you can sometimes see a type AS or shallow trace. This may be due to stiffening of the ossicular chain. Acoustic reflexes are a useful tool to differentiate otosclerosis from other tympano-ossicular causes of conductive hearing loss. Essentially, this involves presenting a tone at 70 decibels above their air conduction hearing thresholds in order to induce the stapedial reflex. With a fixed stapes, an acoustic reflex would be absent, or you may get a variant which is a bifid acoustic reflex, whereas in other causes of tympano-ossicular hearing loss, you would expect to see the acoustic reflex, the stapedial reflex, preserved. It's important to note, however, that as the tone needs to be presented at 70 decibels above the patient's air conduction hearing threshold, oftentimes patients may already have a significant hearing loss that precludes the ability to present tone at 70 decibels louder, and so it's not always possible to obtain acoustic reflexes in such patients.
Okay, thank you for that. So could you tell us what your differential diagnosis would be and what would point you towards the diagnosis specifically?
Sure. I would form a differential on the basis of my clinical examination, history, and audiometric findings. Typically with otosclerosis, they have classical symptoms of progressive hearing loss with an absence of any other otological symptoms. And if this correlates with the classical conductive hearing loss with a Carhart's notch and absent acoustic reflexes, this would be sufficient in my practice to confirm a diagnosis of otosclerosis. However, if the patient had other symptoms such as vertigo or noise and pressure induced hearing loss, I might consider a diagnosis of superior semicircular canal dehiscence. If they had recurrent infections, this may point to lateral chain fixation, and in which case imaging might be useful.
Okay, and so you mentioned about imaging. What would be your choice for this?
So in patients where the diagnosis is uncertain, I'll typically request a high-resolution CT of the temporal bones, and that would classically show lucencies of the otic capsule, either at the fissula antefinestra, but it may show lucencies throughout the whole otic capsule, or in advanced cases, you may see evidence of retrofenestral otosclerosis. It may also demonstrate other pathologies that could be causing the hearing loss, for example, a superior semicircular canal dehiscence, or you might see extensive tympanosclerosis, typically of the malleolar ligaments, which are fixing the lateral ossicular chain.
Right, okay. And so, with the diagnosis of otosclerosis then, what would be your treatment options and possible considerations that you might want to make in this patient?
The treatment options include hearing aids, bone conduction hearing devices, or stapes surgery, and we can discuss the benefits of each. Hearing aids provides a risk-free approach to hearing rehabilitation, and for many patients this would be the option that they would elect. There are disadvantages, however, with a hearing aid, and these include the hassle factor of having a device. Some patients do not get on well with the occlusion effect of having a hearing aid within the ear canal. Some patients may not be able to tolerate this due to recurrent infections. Equally important, many of these patients are young people who might be self-conscious of wearing hearing aids in their working environments and therefore may be motivated to consider an alternative. Other alternatives include bone conduction hearing devices, which can be used on a soft band to be worn as required, or can be surgically implanted as an implantable bone conduction hearing device. The benefits of this is that they do not cause an occlusion factor and are able to be tolerated by patients who may get recurrent infections. However, they do also require an operation, but the associated risks of stapes surgery, such as a dead ear or facial paralysis or vertigo, is not seen with bone conduction devices. And the final option is stapes surgery. This has the benefit of providing a more natural sounding hearing outcome, and it tends to be quite successful, with air bone gap closure to within 20 decibels in around 90% of patients, and an improvement in hearing levels in around 95 to 98% of patients. There is, of course, an associated risk of approximately 1% of a dead ear, but there are also other risks of pain, bleeding, infection, cauda symptoms, which include dysgeusia, which is present in around 20% of people and can be temporary but can last for up to 18 months. Vertigo, which is typically transient and resolves within the first 2 weeks, along with around a 1% risk of tympanic membrane perforation.
Thank you for explaining all the different options. Often it can be quite hard for patients to make a choice with regards to this, given their different factors. So what do you do in order to aid their decision making, particularly in regards to surgery versus other devices?
Yeah, it's really important that as surgeons we provide different options to patients but not lead them to a specific direction. And while we're able to offer different options, ultimately the patient knows best in terms of what option resonates best for their overall lifestyle. So one has to consider the holistic needs of the patient. Patients may feel that they only really have hearing issues in specific circumstances, for example in meetings or when there's a complex listening environment. And they may have adaptations in place that mean that for them a hearing aid is the best option for them. Due to their occupation, may not be able to tolerate certain potential complications of surgery. So for example, if a patient is a chef, dysgeusia could have a significant impact on their livelihood. Similarly, if the patient works at heights or drives HGVs, vertigo would be an unacceptable complication. And therefore, the decision for surgery or hearing aids needs to be made in conjunction with the patient, considering the wider implications on their life.
I think that's important, seeing the patient as a whole really and seeing what affects them specifically. So we were just going to talk a little bit more detail, if you could just explain the pathophysiology behind otosclerosis.
Otosclerosis is an autosomal dominant condition with incomplete penetrance and variable expressivity. What this means is that although a patient may have the genotype for otosclerosis, they may not go on to develop any hearing loss whatsoever. Essentially, it's a disorder of bony turnover known as a bony dyscrasia, and it can be thought of a bit like Paget's disease, where you get disordered bony turnover of the otic capsule. The otic capsule is the densest bone in the body and doesn't turn over bone. However, with otosclerosis, for some reason or other, the bone starts to turn over and you get disorganized foci where the dense otic capsule bone is absorbed due to osteoclastic activity and then replaced by less dense spongiotic foci. Over time, these foci then get filled in by even more dense areas, which are known as sclerotic foci. And these foci can occur at any point over the otic capsule. It may affect, for example, the promontory, which has no impact on the tympano-ossicular hearing, but it may equally affect an area known as a fissula antifenestrum, and that can cause fixation of the anterior stapes footplate, which can then progress to fix the entire stapes footplate, resulting in a conductive hearing loss. Therefore, depending upon where a patient has foci, they may develop a conductive hearing loss, a sensory hearing loss if it starts to affect the retrofenestral area, a mixed hearing loss if it affects both, or they may have no hearing loss, which is why we sometimes see patients with otosclerosis only affecting one ear but not the other.
Well, thank you for explaining that in great detail and giving us real understanding of it then. So we mentioned before about the different treatment options for this, and of course there are multiple approaches to surgery. What's your understanding of the different surgical approaches?
Sure. So while the steps of stapes surgery remain fairly standardized between surgeons, you can consider different approaches in terms of whether you do this under local anesthetic or general anesthetic, using a microscope or an endoscope, whether you do this permeatorally or using an end-hour incision, the order of steps, and the way in which you apply the piston through the platinectomy. So I'll talk to you about my practice along with certain variations. I typically tend to do stapes surgery under local anaesthetic and sedation through a transcanal approach using a microscope. The way I would do this is by creating a tympanomeatal flap, typically a bucket handle, carefully entering the middle ear space, taking care to preserve the chorda. Once I've disarticulated the inculosabetal joint, I will then palpate the malleus to assess the mobility of the lateral chain. This is important because in around 5% of cases you might see some concurrent reduced mobility of the lateral chain, which may account for an incomplete closure of the airborne gap. It's also important to palpate the stapes at this point to confirm that it is fixed. At this stage, I would then perform a limited scutectomy, and the extent of a scutectomy varies by surgeon, but I typically tend to remove enough of the scutum that I can see the stapedius tendon and the posterior cross of the stapes. These would then be divided, in my practice, with a laser, but it can be performed cold steel with scissors and a fine rotating burr to remove the posterior cross. At this stage, I would then down fracture the stapes superstructure, create a rosette within the footplate, and then fenestrate this, performing a platinotomy. Before doing this, I would measure the distance from the long process of the incus to the footplate. And this is an important part because while the majority of patients have a distance of 4.5 millimeters between the footplate and the undersurface of the long process, in around 20% of cases you might see a slightly longer length and sometimes a slightly shorter length. And again, ensuring that you have the right piston length is important for maximizing your chances of getting a good airborne gap closure. I would then place the prosthesis through the fenestration, and then I typically use a laser crimping prosthesis. I would perform a free field whisper test to ensure that the patient's hearing is adequate before sealing the area with a blood patch and then repositing the tympanomeatal flap at the end of the surgery. While that order is fairly standardized, there is an inverted technique known as a fish technique, whereby the prosthesis is placed before the stapes superstructure is down fractured and the stapes disarticulated. The idea for doing this is to reduce the likelihood of incus subluxation during this process. And although it's not something I do myself, I know it's quite popular, particularly in Europe.
Thanks for that comprehensive explanation of it. So then for your patients, what do you do in terms of follow-up?
I typically tend to see my patients at 2 weeks. At the end of surgery, I place a silastic sheet over the tympanomeatal flap along with a Pope wick and cover this with Silodex for 2 weeks. And I see them at their first appointment 2 weeks later to remove these dressings. The patient typically tends to notice a marked improvement when the dressings are removed. I tend to wait 6 weeks till after surgery before obtaining my first post-operative audiometry, as oftentimes there can be some middle ear fluid that may obscure the result of audiometry if you get it too early. Following the 6-week audiometry, provided that there's an adequate airborne gap closure, I tend to not need to follow them up unless they have contralateral otosclerosis and want to proceed with surgery at that stage.
Well, that brings our discussion to an end on otosclerosis. So to summarise, we've discussed about how to diagnose otosclerosis, the investigations management, surgical approaches to it, the benefits of each, patient factors, and how to follow up these patients. Mr. Patel, thank you so much for your time and your expertise. Do you have any closing remarks at all, any top tips for our listeners?
Well, thank you very much, Rahul. It's been a real privilege to be on the podcast. I guess the only other thing I'd say is further materials if you want to check them out. I recommend the ENT Flashcards YouTube channel along with the Head Mirror ENT in a Nutshell podcast series, which are both excellent learning resources.
Thank you once again to Rahul and Mr. Patel for their informative discussion on otosclerosis. And thank you to our listeners for tuning in. Please be sure to subscribe to our podcast, the AOT Pod, to be notified when new episodes are released. See you next time.